Welcome. My name is Kelly Pfeiffer. I'm the Director of California Healthcare Foundation, and I want to welcome you to the first webinar for the Care Integration Planning Grant Group. We're delighted to have Camden Coalition join us to teach us about their coach model. As a reminder, we at California Healthcare Foundation do not have one model that's a cookie cutter that fits all populations, all situations. And our goal over this planning grant process is to expose you and introduce you to different ways that people across the U.S. have tried to solve the same problem, which is how to identify patients who are high cost to the system, not getting benefit from that very intensive medical care, and need a much more intensive, integrated, comprehensive approach. Many of you may know the Camden Coalition from the very famous New Yorker Hotspotter article that turned them from a small little organization doing the right thing in New Jersey to a nationally prominent organization. And I've heard Jeff Brenner say that that was a little bit about suddenly having a fire hose of attention and having to get organized very, very fast. So Camden is really one of those success stories that we're able to take a small model that worked for them and then translate it into models that they can then support exporting to places across the U.S. where people can adapt this model to different settings. We particularly called them in to talk about their coach model because it solves a couple problems that you may be facing. One is that you all may not have a model where you can identify patients, engage them, and keep them forever. And this is something we talked about with Corey Waller and the Spectrum Health integrated clinic model, that a lot of their patients never graduate. Camden faced the same problem of how to provide care for patients and then not be there for them indefinitely, because again, not all of us have infinite staff, and sometimes the need feels infinite. So they've done a very great job of innovating and adapting to their model to really encourage every person who works with a complex patient to help that patient become capacitated, engaged, and take charge of their own health so they can actually graduate them from care after they've achieved some goals. So with that in mind, I'd really like you to think about how does this model apply to the type of training you might provide for providers and staff, and then how do you think about whether your model will hang on to patients indefinitely or will help them achieve some short-term goals and then potentially graduate them with the idea that they will have more skills than they did when they started. A couple logistics, because we're a pretty large group, if you have a question, we ask you to use the hand-raising button on your screen. So just click that hand and we'll notice that you're raising your hand, and unmute your line so you can talk. We also have a chat function, and you're welcome to type in your question, and we'll make sure it's addressed by the end of the webinar. We will make the PDF of this presentation available for you, and Camden has been committed to help others learn about their model so they can also answer questions afterwards. Finally, we will have a recording of this available for anyone who was not able to join us today. So I'm going to turn it over to Catherine Royer and Brian Akers. If you can introduce yourself, and we're going to have you take it from here.
Great, thank you so much for that wonderful introduction, and we are both so excited to spend the next hour with you. My name is Kat Royer, and I'm here with Brian Akers, and we're both from the Camden Coalition. We both have a pretty similar history at the organization, so we both started about 3 years ago as AmeriCorps health coaches, so we served on our interdisciplinary care teams here at the Coalition and worked with complex patients in the community. Since then, we've actually both transitioned to our cross-site learning and workforce development department, and our primary roles include curriculum development. So very similar to the webinar that you're going to see here today. So working, with internal staff with respect to the coach model, but also starting to share the coach model externally as well. So we really broke our presentation up today into 3 different segments. So the first segment is really about who we are and what we do. And then the second segment, we're really going to get into the coach model. And then the third segment, we're going to focus on some best practices and lessons learned over the years. And just for the sake of time, a lot of this information is going to be high level, but we're going to pause after each segment, and we really invite you to ask any questions that you may have. And if for whatever reason we can't get to your question, we'll be sure to follow up with people individually if need be. So with that, I'm going to pass it off to Brian, and he's going to give us, again, a high-level overview of who we are and what we do.
Hi, everyone, and thank you, Kat. So as mentioned, we're just going to start with kind of a little bit about our organization. But we can't talk about the work we do without first talking about the city in which we work and, more importantly, the city in which our patients reside. So Camden is a relatively small city, a population right under 80,000. Unfortunately, every year it's ranked in the top 3 most crime-ridden or poverty-stricken cities in the country. There are 3 hospitals in Camden, New Jersey, and about 10 years ago we started as a subsidiary of one of those hospitals. And what we kind of were recognizing was that, as many of you are probably aware, that there was a small number of patients that were kind of coming in and out of the hospital over and over and over again. And being data-driven in nature as we are, we kind of wanted to put some numbers to that. So we signed a data sharing agreement with the additional 2 hospitals in Camden. And what we did was we took a look at over 500,000 records over the course of 9 years among 98,000 patients. And the first thing we recognized was that about half the population was using the hospital or the emergency room every year. But more importantly, we wanted to find out kind of how that's distributed among cost. So we built what is famously called our cost curve. So on the x-axis, you have the percentage of all patients, and then on the y-axis, you have percentage of all costs. So just to give an example, so at 10% of the patients in Camden, we're accounting for 73% of costs. 5% of patients were accounting for 58% of costs. And then astonishingly, 1% of the patients were accounting for over a quarter of all healthcare costs. So naturally, we kind of figured, well, if we can build an intervention to target that 1% and reduce their hospitalization, we can save the system at large a ton of money. And that's kind of what the term hospitalizing stems from. As many of you are aware from the article in the New Yorker, we kind of have a working definition of this, but it's exactly as the cost curve demonstrates. We want to use data to identify stresses and inefficiencies within a system, and as a result, target resources to a specific population. And that's what we did, right? So we used claims data to identify a financial stress on the healthcare system, and as a result, we built an intervention to target a specific population, again, that 1% of the population. But we didn't know much about this 1% of the population until we dove into the work, right? And anecdotally, what we learned is that this specific population that we were referring to, the population that we wanted to reduce hospital utilization with, were incredibly complex. But complexity is one of those words that's kind of thrown around in healthcare far too frequently and with limited scope. So traditionally in healthcare, we view a complex patient as someone with comorbidities, right? So maybe someone has COPD, which is a breathing disorder, heart conditions, diabetes, high blood pressure, foot ulcers. And if these individuals with maybe 2 or 3 different diseases or illnesses are coming back and forth to the hospital over and over again, despite hospital suggestions and doctor advice, what do? We label them non-compliant. For the most part, we don't consider all the other social correlates to their health. So we don't recognize the fact that, maybe the reason the person isn't attending their dialysis is because they don't have transportation. Maybe we're recognizing the fact that an individual isn't taking their high blood pressure medications because they can't read the prescription label. They don't have a home to store their nebulizer in, which is a breathing device. So complexity in our mind and how we discuss it with our partners is just social and medical needs that the patients have. But not all patients are medically complex, right? Not everyone going into the hospital is medically complex. So we needed to find a set of criteria to identify and engage individuals that would benefit from our intervention. So we're fortunate in Camden. We have what's called a health information exchange, which is essentially a citywide shared electronic medical record. And every morning we receive a live feed of every patient who's admitted into the hospital over the last 24 hours. From that list, we triage, right? Again, the idea is we want to find patients who we think can benefit from our organization. And our triaging process is actually pretty easy. It's a 3-step criteria. So the first thing is that we want to make sure that the patients that we're engaging have 2 or more hospitalizations in the last 6 months. Again, the idea is these are the patients that are going in and out of the hospital who hopefully we can prevent readmissions. But secondly, we want to make sure that the reason they're going to the hospital is for chronic conditions. So we don't want an individual who's going to the hospital for an acute condition, right? Maybe someone had 2 surgeries in the last 6 months, but they have no more surgeries scheduled. There's not a whole lot we can do with there. Or an individual who had chemotherapy but is in remission now. And finally, the third thing that we look for is social barriers or correlates to their health. So just to give you an example, I know the text is kind of small on this page, But to give a few examples is someone who has a language barrier or low health literacy, someone who has a mental health disease or is actively using drugs, homeless or uninsured. Again, this ties back to that idea of complexity. So once we've identified patients through this 3-step process, we meet them bedside.
Great, thanks, Brian. So, Brian briefly talked about how we actually identify this 1% of the population that's incredibly complex. So once we identify them, now I'm just going to walk you through what our intervention looks like from start to finish. Again, this is really high level, but we'd be happy to address more specific questions that you have. So as Brian said, we meet people at the bedside when they're admitted at the hospital, and that's when we start to have a conversation with them about their health and social needs and their potential interest in the program. And what's really unique about engaging somebody at the bedside is that it really represents an incredible opportunity where they may be vulnerable and more likely to have a conversation about their health and social needs and might be more at a point of change in their life. And what's also really great about meeting somebody in the hospital is we really can take the time to learn their story, learn the barriers that they face, and start to build a relationship with them. And we find that this relationship in the hospital really sets the stage for the whole intervention. And then once somebody is discharged to the hospital, usually within 1 to 2 days of discharge, we meet the patient in the home. So here's a picture of one of our patients with an LPN and a health coach at a typical home visit. And what's really great about home visits is that it gives us, again, incredible insight into, again, not only the medical complexity, but the social complexity that a lot of our patients are dealing with. There's been many times when a lot of our nurses have walked away from a home visit with, bags of expired medication. So again, it really gives you insight into someone's living conditions, their level of social support, just as an example. Another big component of our intervention is accompaniment. So for example, this is going to a provider appointment with a patient, sitting with them in the waiting room and actually being in that room with the doctor. Because again, it's a really great opportunity to learn about the patient-provider relationship and serve as an advocate for that patient. And then next, a big part of what we do is community visits. So again, this could be going to the Board of Social Services with patients. Another example is in this picture here. So this is a picture of Bill. He's one of our intervention specialists, so he does a lot of work with housing. And he's at Walmart with one of our patients shopping for new items for their apartment. So again, meeting patients in the community, again, gives us great insight into the system that they're trying to navigate, and also is a really great way to start to build relationships with patients. And then lastly, our intervention is short-term. So when patients have accomplished a lot of the goals that they've set out to accomplish, and they are at a point where they can manage their health and social needs on their own or with the help of a long-term resource, we graduate them from the program. And what's really great about graduation is that it's special for everyone that's involved. So we actually give our patients a certificate of achievement, which is pretty much like a graduation diploma. And what's really great about this is, we've heard patients say, I've never graduated from anything before, and they hang it on their wall. And it really is a proud moment for everyone. And so one of the themes that comes up time and time again with this work is that it's really hard working with complex individuals. So what we found really important is that it really does take a village. It really does take a good team to do this work. And really there's a couple things I want to point out about this slide. I would say don't necessarily pay attention to the overall structure, but there's just 2 things that I want to highlight. So first and foremost, we have 2 care teams that are interdisciplinary. So again, as Brian mentioned, medical and social complexity, we feel like we need to have a team that balances that expertise. So our team is composed of nurses, which bring that medical expertise. We also have a social work team that brings that expertise. And then we also have community health workers that have the knowledge and the expertise from the community. And then secondly, the other thing I want to highlight about this team structure is that both of our care teams are led by a dyad. And so what that means is that there's an RN clinical manager paired with a program manager. And this is really all about balancing efficiency and effectiveness. So the RN clinical manager obviously brings a great deal of medical expertise, but really their primary role is to make sure that the team is providing good care, that is effective care. making sure there is a care plan in place, making sure that that care plan is progressing. And then the program manager is really focused on efficiency. So are we actually seeing patients within 1 to 2 days of discharge from the hospital? And are we actually seeing patients every 7 days to keep that relationship? And so now I'm actually going to pass it off to Brian, who's going to talk a little bit more about that efficiency piece.
Yeah, so as Kat mentioned, efficiency is a big part of what we do here. Are we being productive with our time? And so I don't want to get bogged down on this topic for now, but the idea is that we have a large number of metrics that we track, not only patient progress, but also just kind of our interactions with the patients themselves. And so what we've done here is we've snapshotted a few of our dashboard images just for you to get a sense of. And I'll specifically focus on the top right-hand image. So this is a way that we've tracked over the course of time the percentage of our patients who have managed to get a primary care appointment within 7 days of discharge from the hospital. We've recognized there's a strong correlation between that and the likelihood of readmission. So that's just one thing we're checking. And in terms of efficiency, we're trying to ensure that we're always improving that number. But as Kat also mentioned, effectiveness is important. So are we providing good care to our patients? And one way that we've kind of codified this idea is through our care tenets. So we have 4 care tenets that I just want to briefly address. So the first is to stay community and hospital-based. This is what Kat talked to. You can't get a true sense of a patient's life and the complexity of their health until you see them in their home and in their community. A medical reconciliation is a great example of this. We've gone to patients' homes, and you can see them in the hospital, give them a list of discharge orders, and you go home and they have medications from 3 years ago. They have no idea how to manage their medications. So there's that disconnect between hospital and community. The second tenet is trauma-informed care. So many of you are probably aware of a study that was released in the 90s called the Adverse Childhood Experiences Study, which linked traumatic events early in childhood with adverse health behaviors and health outcomes later in life. And at the Coalition, we actually assume that all of our patients have experienced trauma at some point in their life. The third is to practice an acceptance framework. This, simply put, is just meeting a patient where they are in their life, regardless of the situation. And I've highlighted a couple bullets here, kind of underlying themes that help to address the acceptance framework, which we'd be happy to discuss in depth or for you to research at a later time. But those are unconditional positive regard, empathy, harm reduction, and motivational interviewing. The fourth and final care tenet that we share here at the Coalition is to remain patient-centered. So again, this is incorporating the patient's needs, desires, and situational aspects of their life into the care plan and into the intervention itself, while remaining centered on a holistic approach. So we incorporate, as we mentioned, again, back to the complexity piece, the biopsychosocial aspects of their health. So that's kind of the overview of our actual intervention itself. We're obviously going to jump into the how through the coach model in a moment, but we wanted to pause for 5 or so minutes just to address some of the questions related to this portion of the presentation.
Thank you, Kat and Brian. This is Kate Myers. I'm here with Kelly. So at this point, if anyone has a question, you can feel free to use the raise your hand function. Okay, there is a question here. How did you determine the cutoff for number 2 or more hospitalizations within the last 6 months?
So one of the questions that's frequently asked is, so why did we determine to only work with inpatients, right? So the number that I gave of 2 inpatient admissions refers, again, only to the inpatient aspect of the hospital, does not refer to the ED. We don't work with, at least we're currently piloting actually a program to work with ED high utilizers. And of course there is overlap. But we target 2 hospital admissions in the last 6 months. Partially, in part because, we've recognized that this number is where the cutoff for high utilization begins. We'd be happy to kind of share some additional data and numbers around that, but that's just kind of what we've learned from best practices and learned in terms of, what we can reduce in terms of the hospitalization while still having a panel size large enough to have an impact, if that makes sense.
The second question was, how many individuals were in your top 1% given a patient population in Camden of 85,000?
So the 1% actually fluctuates, so it's not a static number. So it's dynamic in the sense that individuals sometimes leave geographically. So again, that 1% was referring strictly to Camden. So the 1% though either sometimes leaves geographically, moves in. Sometimes individuals that are high utilizers for a number of years, naturally become low utilizers. It's the phenomenon of regression to the mean. But ideally, the 1%, I don't have a strict number on it. But again, the idea is that we are constantly. It's not like there's a 1% of the population and we're kind of chipping away at it. It's constantly fluctuating.
And something we are in the middle of doing now is a randomized control trial. So over the next couple years, we're aiming to have about 800 people enrolled into the trial, again, to really see the impact of our intervention. So that's one of the numbers we're kind of using right now, is that 800 number specifically for the RCT, because we think that population will give us a good starting point to see the impact of our intervention.
So the question had to do with identifying problems that came up during the study and then adjusting the types of variables you're looking at.
Hi, Darren. Thank you so much for that question. I think I have an example that might speak to your question, but let me know if I'm not getting at it. One of the things we've definitely noticed, you know, in the past 2 years with this work, that a lot of our patients that we work with are either homeless or have housing instability, and this is obviously a big factor that is driving them back to the hospital. So we actually just recently started to implement a housing first pilot. So we've developed partnerships locally and also at the state level to start this pilot, so that when we're actually working with a patient, regardless of, you know, whether or not they're actively using drugs, you know, if they need housing and that not having housing is a driver of them going back and forth to the hospital, then we will try and enroll them in our housing first pilot and get them housing. So that's, I think, something that a problem that we've observed in doing this work, that housing is so important, and how we started to address it, you know, using policy. Is that kind of getting at what you were asking?
Yes, thank you.
Yeah, no problem.
Okay, thank you. And I'll mute your line again in a moment, Darren, just for background noise. And then another question that came in was, on average, what is a team panel size?
Sure, that's a great question. Thank you. I think on average, the panel size per team is about 25 to 30 patients.
We've actually upped it recently just due to kind of improvements in efficiency, but we're closer to 40 now at any given time. So that panel size is obviously cycling in and out as we graduate patients, but it's closer to 40 at this time at any given time. Yep, and again, we have 2 teams, so a total of 80.
Okay, thank you.
We'll go ahead and we'll move on to the next segment. And again, we're really looking forward to answering more questions later. So now we're going to talk about the coach model and kind of how we started to think about developing it, how do we implement it with our staff here at the Coalition. And so again, as I mentioned before, something that Jeff often says is that there really is no manual to do this work. There's no, you know, unfortunately, step-by-step instruction guide to working with high utilizers. So that being said, we really started to think about the past 2 years, you know, how do we actually prepare and train our staff to do this work that is incredibly complex? And so just a brief anecdote, you know, when Brian and I started as health coaches, this was probably about 3 years ago, the way that we really learned how to do the work, the way that we learned to engage patients and build relationships was by watching other people. So just going out in the field and watching our nurses interact with patients, and that's how we learned. But as you know, we've rapidly expanded over the course of the past 2 years, we really started to see the need for the development of a training model. The other thing that was happening around this same time was that we were starting to get the results of qualitative interviews with patients that had graduated from our program. And we started to see this interesting theme emerge. So it seems that, you know, we did a really good job of kind of being problem solvers with our patients in the moment. We did a really good job of kind of going in like a SWAT team and taking care of all their issues for them. We weren't, however, doing a really good job of teaching them. So leaving them with skills so that they could sustain their health and social needs when we weren't in the picture anymore. And so I think this quote on this slide does a really good job of summing that theme up. So when they fell off, I kind of fell off. When they were there, I was more energetic maybe, or persistent on doing what I was doing. So thinking about the development of this training model, thinking about making this shift from being problem solvers to teachers, all of that kind of led to the culmination of the development of coach. And so before I get into the coach model, I like to bring this picture up because, again, as Brian mentioned, you know, our patients are incredibly complex. Not only are they dealing with complex medical and social issues, but they're also trying to navigate an incredibly complex system. And so again, we really started to think about how can we teach people to navigate this system on their own when we're no longer in the picture. So coach, again, is really all about how do we coach people in a way that they can achieve goals while we're working with them, but at the same time, we're also leaving them with skills so they can sustain on their own when we're no longer around. So coach is an acronym, and so each letter represents a different lesson that we rolled out with our staff, and we started to roll out externally as well. And so each letter either represents a philosophy that's very much grounded in patient engagement or motivation, or there are some letters that are actual tangible tools that our teams have started to take in the field. Again, all really centered on, patient priorities and patient motivation and engagement. So I'm going to pass it off to Brian. We're just going to briefly give a high-level overview of each letter, and we'll start with backwards planning.
Sure. So create backwards plan kind of is meant to address, as a whole, how you build a care plan, so how you really start the work with patients. So at the highest level, backwards planning is a physical tool to highlight patient priorities and discuss where someone wants to be. So what do I mean by this? Well, I want to start by sharing an image with you. So this is a patient of ours, Michael. And what we recognized a number of years ago when we first started this work, that there was a disconnect. Our care teams thought something was important, and they wanted to work on that. And the patients thought something else was important, and they wanted to work on that. And we entered this kind of tug-of-war scenario, right, that I think a lot of clinicians are probably familiar with. So we kind of flipped the script, and we said, you know what, all right, we're going to stay patient-centered. And what we want you to do, Mike, is we want you to just write down every single thing that you want us to help you with. No exceptions. And what he did was, if you take a look at the list here, I know it's not always easy to read, but only 2 of the things he wrote down are actually medically based. This was kind of our aha moment, right? This is why there's been that tension, because we're addressing things in the wrong way. We created the same kind of experiment with a large number of our patients, so we had a lot of our patients fill out a similar list. And what we did then is we took all of these answers and we kind of boiled it down to 14 what we like to call care planning cards. So just to give you an example, get a job and or go back to work, talk to someone about my mental health, help people in my community, have support, food and nutrition. These are the 14 care planning domains that we found are most related to our patients' lives and what they most want to work on. And what we did was we took all 14 of these and we printed them on cardstock and we cut them into individual cards, just like playing cards. And then we built a board. So it's a 4-cornered board that simply addresses for the patient to answer, need to work on right now, first need to work on later, don't need to work on right now, first don't need to work on later. And the idea is the patient, again, takes these 14 cards and simply places them on the board where they feel appropriate. And what really matters from this activity is that what they put in the top left board, so this is what they need to work on right now, is of highest priority. So sometimes this is a crisis or a deadline. But the idea here is that whatever they put in that corner is what we're going to work on with the patient. Even if we think, for instance, their addiction to a substance is most important to their health, if they don't put that card in that corner, we're not going to address it, at least for the time being. So this is how we build our care planning. This is how we build our care plan. We address the patient priorities and work with them to accomplish it. Here's just an image of what it looks like in practice. So this is the board itself taken with my cell phone. As you can see in the top left corner, 2 of the patient's cards were identification and have transportation. So these were the first things we were going to address with the patient when we started the intervention.
Great, thanks, Brian. So I think backwards planning is a really great tool because it not only ensures that we're having a conversation with a patient that's grounded in patient priorities, but it really ensures that all of our care team members are going about it in the same way. So next, I just want to transition to talking about O, which is observe normal routines. So actually, O and A, assume a coaching style, are really grounded in teaching. Victoria, our clinical director, who was really involved in the development of this model, actually was a teacher beforehand. So she really brought a lot of that expertise to the table. And so again, this is all about how do we teach people, how do we expand their range so that they can have more problem-solving skills and sustain when we're no longer in the picture. So the key point of observing a normal routine is really simple, but it's actually really hard in practice, as we found as an organization. So really the idea here is that before we actually step in and problem solve for a patient, before we say, I'm going to make that appointment for you, I'm going to take care of all your medication for you, we actually step back and we ask questions. And that can actually be really powerful. And something that really stood out to me, and I think Brian, as a result of our experience as health coaches, is that our patients are incredibly resilient people. These are people that have been managing their health and social needs, for decades. And so really stepping back and asking questions allows us to really appreciate and acknowledge patient strengths and understand what's worked for them, what hasn't worked for them in the past. And then based on that information, we can start to build strategies and systems off of that and make them more effective so they can be more sustainable long term. So we actually have a video that we were going to share, but due to technical difficulties, we're going to skip over it, but we will send out the link afterwards. So this is actually Mark Morales. He was one of our health coaches a couple of years ago, and he does a really beautiful job of kind of summing up the impact of observing a normal routine in the field. He talks about a time he did and didn't do that. So he talks about how, one of the patients he was working with, she would always get taken to her appointments by her daughter. And Mark kind of just wanted to step in and problem solve and tried to set her up with reservations for transportation. And he tried to set her up with this, elaborate system for making those reservations. And ultimately, it didn't work out because she already had a system in place for getting to and from her appointments. But then on the flip side, Mark also reflects on a time he was working with a patient who had memory impairments, and he recognized that she actually did a really good job of using her voicemail to play back any important messages she would receive from friends or family. And so Mark just actually applied that system to her health needs. So he would just encourage her providers to leave messages for her so that she could replay those messages if necessary. So again, O is really simple, but it can be a really profound way, again, to build a relationship with somebody, but also to really start to build long-term strategies that will work for the patients you're working with. And now to talk more about teaching, to talk more about how can we actually start to expand patients' problem-solving skills, Brian's going to talk about coaching styles.
Right, so as Kat mentioned, a primary focus of our intervention is to set patients up with knowledge, tools, and mindset so that they can sustain their own health when we're no longer in the picture. But how do we coach them to that point, right? So not to simplify the patient-provider relationship, but we've recognized that it's actually not a whole lot different than coaching in any given sport. So we'll use soccer as an example. Let's say you want to learn how to shoot a penalty kick or to perform a new move on a defender. What do? Well, first, you watch your coach, right? Your coach demonstrates the activity. Second, you practice that activity, and you do so under the guidance of your coach still. So your coach is there, and what he does is he helps fill in any gaps, any issues, or any problems you face while you practice that activity. And if you practice enough, sometimes for a short amount of time, sometimes for a long amount of time, you ultimately develop the ability to do that skill on your own. So we think the same thing applies to healthcare. And we've kind of boiled this down to 3 key words we like to use. I do, we do, you do, right? So the idea is simple. So I do is myself. I'm the provider. I'm going to do the skill first for you. Secondly, we're going to do it together, the patient and provider. And finally, the patient is going to do it on their own. So let's use an example. So let's say a patient needs to schedule transportation to a medical appointment, and they've never done so before. The first thing we're going to do is we're going to model the skill while the patient watches. So I'm going to call the transportation company with my phone on speaker, and the patient's going to listen. Next time, the patient is going to call with the phone on speaker, and if she gets stuck anywhere along the way, I'm going to fill in the gaps. So again, we're doing the skill together, and I'm assisting as needed. And when the patient's comfortable, the patient's going to take the lead on the activity, and they're going to do it on their own. So they're going to call transportation, and I'm not even going to be there. But what I will do is I'll support as needed. So I'm going to check in with that patient at a later time to make sure that everything went okay. So again, the idea here is that patients need us to assume different coaching styles. So the I do, the we do, or the you do, depending on the situation and that person's level of dependence. Because we're trying to get a patient to a level of self-sufficiency so that they can manage their own health on their own.
Great. And now I'm just briefly going to go over the last 2 letters of coach. And I think these are really tied to motivation. So, we just talked about observing a normal routine and the different coaching styles. And obviously, when we're working with people that have complex issues, it's not a perfectly linear process. We oftentimes see that, we're working with patients that have a lot of goals, they have a lot going on, and it's really easy to get lost in the day-to-day task work and get overwhelmed. So it can be overwhelming for patients that want to accomplish a lot and are having a hard time. It can be really overwhelming for us as a care team. So I think these last 2 pieces that are tied to motivation are really important. So first we're going to talk about connecting tasks with vision and priorities. So really, we like to frame motivation as being 2 parts. So the first part is really tied to vision. So this is the I want. So showing someone that a task, a smaller goal that they're working towards is connected to something bigger that they want for their life. And when I say bigger, I'm talking about something that's bigger than being healthy and staying out of the hospital. So really starting to understand, why do you want to be healthy? Why do you want to stay out of the hospital? What's really important to you? So on this next slide, I just have some patient quotes. These are things that our care teams hear regularly. These are things that Brian and I have heard that are tied to those bigger visions. So it's things like, I want to be healthy and stay out of the hospital because I want to be able to travel to see my sister. I want to reconnect with my family. I want to be able to just live a normal life. And so we think that really taking the time to understand what patients want for their life can be really powerful, because when they're feeling really overwhelmed, when we're having these tug-of-war moments, we can start to tie those smaller tasks to the bigger vision. So it could be something like, I remember, Mrs. Smith, you said that you wanted to make that trip to see your sister. And if you go into this provider appointment, you're going to get your medication taken care of, and that's going to help you make that trip. So again, it's just being able to articulate that vision back to the patient as a source of motivation throughout the intervention. And what's really interesting about this idea of vision, or I want, is that when our clinical director, Victoria, was kind of reflecting back on all of the patients that she had worked with over the years and talking with our other care team members about what they have experienced, we started to realize that there were these common themes of vision, or what somebody wanted for their life. And the 3 themes are listed here. So these are significance, love and belonging, and certainty and safety. They're pretty self-explanatory, but really significance is, the desire to feel important, to feel like you're contributing to society. Love and belonging is really all about, feeling like you're supported, feeling like you belong to a community. And then certainty and safety is really all about, having a plan, knowing what's coming next in your life. And these are all things that, we all want in our life. But when we also think about our patients who are dealing with homelessness and other really hard issues, it's really easy to start to see how all of these things could apply to those underlying things they want for their life. And so we started to use this language not to label people, put people in buckets, but again, really start to think about what are the underlying things that patients want, and how can we start to address those underlying issues. Because we find that if we don't start to address those issues or connect them with a resource that will address those issues, then we're not going to be successful, and they're going to wind back in the hospital. So I just want to talk a little bit more about, again, why is this language important to us? So again, with vision, it's all about being able to motivate patients, being able to connect that task or that goal on the backwards planning board that Brian mentioned to something bigger that they want for their life. And then secondly, it's really beginning to think about, what are the underlying issues? What does this patient want for their life? And how can we tie them to a community resource or an individual in the community that can help address that issue? So for example, for someone that's homeless, it could be getting them housing. For someone who is extremely lonely, it could be, signing them up for a bingo group. We find that, while the medical issues are important, we find it's really addressing these underlying issues that make a huge difference with our patients. And so next I'm going to pass it off to Brian, who's going to talk more about motivation.
Right, so the last letter in COACH is H, which stands for Highlight Progress with Data. So if we think back to what Kat mentioned about motivation, she discussed the first way that we can motivate our patients and just people in general, which is to identify what they want and work on them to address those wants. But the second way is to show those individuals that they can actually accomplish those goals, right? That they can do this. And that's what highlight progress and data stem from. So if we think to kind of a situation that maybe a lot of us can relate, for people that want to get in shape, what do? They often take a before and after picture and then probably 1,000 pictures between, right? Why do they do this? Because they want tangible evidence of the progress they're making, because that evidence motivates them to continue to reach their goal. And this is what we want to do with our patients. So if we think back to Mike, he has so many things that we wanted to work on with him, right? And sometimes it's easy to get lost because not only because the work's hard, but because it oftentimes takes a lot of different steps. But if we can show him visually that he's making progress, even if it's small step-by-step increment improvements in each of these domains, that can help to motivate him to continue through. So again, the idea here is that by highlighting progress, we can motivate the patient through the complex care plan that we've developed. So what we've done actually, we've taken a lot of the times that we spent with patients, and we've actually built out a couple different ways to do this. So these are physical tools that we hand to our patients that are printed on cardstock as a means to kind of highlight their progress. So I'm going to bring one up as an example. So you'll notice this, again, this is something that patients can hang on their fridge, keep in their folders, whatever. You'll notice at the top that it addresses the Connect Task with Vision that Kat spoke to. So I want to stay healthy and out of the hospital because, and a patient could fill in whatever overarching aspect of their life that they want to address. And then for each of the 4 boxes below, the patient will write in 1, 2, 3, or 4 of their top priorities in terms of the care planning. So again, these are the cards that they put in the top left corner of the backwards planning board. And then as they progress from through the I do, we do, you do spectrum, we can mark that on the board. And if any big win occurs, we'll write that down also. So let's say that a patient wrote down as their first priority that they wanted to improve their relationship with providers. A big win could be that they found a new primary care provider who they really like. Again, the idea is that the patient can constantly reference this document as a way to continue to motivate them. They can see that all the work they're doing is actually going towards something.
Great. So, Coach, it really comes down to how do we teach our patients? How do we motivate them? How do you really set them up for long-term success? And so we've had really great success kind of rolling out this training model with our staff. But in all relative terms, it's a relatively new model that was just developed about almost 2 years ago. And so I just wanted to spend a little bit of time talking about, how did we actually roll this out to our staff? How do we actually start to make the shift from, being problem solvers to being fixers for our patients to being more teachers or more motivators for our patients? So I just wanted to quickly go over a few things that I think have been really helpful along the way to create buy-in around this model, and also just implementing the model overall and starting to really change the language within our care teams about motivation, about teaching. So I think first and foremost, framing was really important. So when this training was rolled out to our staff, we weren't saying you're doing something wrong, you have to change your ways. It was really more about we're really just trying to put onto paper what you all do every day. And we're just trying to give you language and give you tools that will make your jobs easier with all of your patients. And then secondly, we had the initial training with our staff, but then we've, made a lot of effort to have regular refresher trainings to not only refresh on the content, but we also invite our staff to bring, real patient scenarios so we can actually talk through coach with them. So it really brings the content to life and makes it more meaningful for people. And then lastly, since the beginning, we've had, ongoing check-ins with the clinical managers or the team leads, because we find, if they're involved in the process, if they're involved in helping us to develop some of these tools, then they're going to become bought in, and then that's going to trickle, all the way down. And then as we talked about, we have these tools that are very much, teaching and motivational tools, like the backwards planning board and the highlight progress with data templates. And what's great about these are tools that our teams can take in the field and have been really, really helpful for having conversations with patients. But they're also tools that ensure that our teams are using the coaching language. And then lastly, what's also been helpful is Victoria, our clinical director, she did some shadowing in the initial rollout of Coach to really see if people were starting to make the shift based on the training that they received. So, you know, the model is still relatively new, and it's definitely still a work in progress, but we've definitely started to see a shift. We've definitely started to see people start, you know, using the I do, we do, you do language, which has been really great. And so that concludes our segment on the Coach model. Again, it was a pretty high-level overview, but we would love any specific questions that you have about it.
Well, thank you so much. Again, this is Kelly Pfeiffer from California Healthcare Foundation. Every time I listen to you, I learn more. And I think one perspective I wanted to add is these are skills that a lot of us growing up, going to professional school, integrate in our lives without even thinking. We set our own priorities. We don't let anyone else decide that. We set goals. We figure out what we need to do to get to those goals. We had parents and others who helped us by letting us see one, do one, and then often teach one directly. But what Camden has really done a beautiful job is breaking these down into really concrete steps that can help people who've never had this type of advantage and have been taught through the system that a legitimate learned helplessness, that no matter what you do, you'll get knocked down, so why try? And so again, even though they have focused on a different population than this particular grant focuses on, the skills that they've laid out, we really think could be helpful. And again, since they've developed a train the trainer model, these are skills that we could certainly facilitate bringing to you and your teams later if they're helpful. So any questions?
Yep, so you can feel free to raise your hand or type in a question. Looks like we've got one written down. How does your model address resistant or stubborn providers who are unwilling to change practices?
Yeah, that's a really great question. I think we are still we're still working on that. I would say that, you know, with the rollout of Coach, we've really been focusing on our internal clinical staff. But we have, it's really interesting, recently we've had some interest from local practices who are really interested in the Coach model because they've heard about it from us or from somebody else. So we're fortunate enough in Camden that we have started to develop pretty close relationships with a lot of the practices, probably because, you know, it's a relatively small city. But as people kind of learn more about us and the work that we do, they start to become kind of interested in the training because they're encountering, you know, the same resistance from patients that we oftentimes encounter. So they're always looking for ways to kind of overcome that. So I guess to summarize that, we're kind of working on it.
Yeah, but I also think it's really important to kind of approach it from a learning perspective also. I mean, we're not suggesting that this is the only way to approach patient care. We're suggesting that this is some of the lessons we've learned. So to give an example of that, you know, we've worked with medical assistants, primary care providers, et cetera, in the community, individuals who are entirely clinic-based. And of course the question is, okay, well, what if this applies? And you know, we again approach it from a learning perspective. What can you teach us, or how can we specify this to you? So to give an example, the backwards planning board doesn't necessarily apply to maybe someone who's just a provider in a clinic, right? And instead what we did was we took the backwards planning board and tweaked it and shifted it from what you want to work on to what do you want to talk about with your doctor today. And it's something that they can fill out in the waiting room, you know, or play with the cards while they're in the waiting room. And that is, again, just to kind of build the buy-in, show, you know, the providers, et cetera, that we're all in this together. Because underlying all of this work is truly that we're trying to, you know, better our patients. And I think that as long as that's coming through and staying patient-focused, I think it's much easier to get individuals kind of aligned.
Great, thank you. We have a couple more questions here. So the next one is, what is the coach to participant ratio?
We have 2 care teams that are interdisciplinary, and then they each manage a panel of about 40 patients. So really with rolling out the training, I mean, we train everybody on the care team. So it's everyone from a health coach, you know, up to the RN in this coaching model. So typically over the course of the intervention, the whole team is involved just at different points. So for example, the RN and the LPN might be more involved in the beginning and focused more on the medication reconciliation process. And then towards, as the intervention progresses, it might go more towards the community health worker and the health coach, who are more kind of just making sure that the care planning is progressing and doing more of the teaching. So I would say, the whole team really serves as a coach for the patient, just at different points in the intervention.
One other question came up about where your organization came up with, or how your organization came up with your three-part model of human motivation, where you talked about love, significance, and certainty, as opposed to what this person brought up as kind of the Maslow model of food, shelter, and clothing. So can you describe a little bit about how your organization came up with that model of motivation?
Yeah, absolutely. So the model was mainly developed as a result of Victoria, who is our clinical director. And prior to joining the coalition, she was actually a teacher. She did Teach for America. So I believe a lot of the framework, especially the I do, we do, you do, came from Teach for America. And with respect to the connect task with vision piece and the themes of wants or desires for somebody's life, the story that Victoria always talks about is how, in her apartment, she just would have all of these Post-its up about all of her patients and like what their needs and wants were, and then just started to kind of boil down all the things, on the Post-its to common themes. So it definitely has a lot of resemblance to Maslow's hierarchy, which I think is really interesting. But I think that piece specifically just came from our experience in the field with patients. But then it was very much supplemented with the Teach for America framework as well.
And again, the language isn't meant to be absolute. As Kat mentioned, however you want to frame it, it just in part is meant to create some kind of a common language within the organization so that we can discuss patient needs among ourselves. There's plenty of times where we walk downstairs and we hear first time one of our clinicians has met a patient, they say, oh, this person is low in love and belonging. I definitely want to connect them to, or I assume they're low in love and belonging. I definitely want to connect them to, say, a day program. Something like that. There's something that kind of is easy for our team to communicate and kind of strategize around.
Okay, one other question. Earlier you said that if a patient didn't want to address an addiction immediately, it wasn't forced on them. Would it eventually be addressed, or would people graduate from the program without addressing addiction?
Yeah, that's a great question. So if we go back to the backwards planning board, there's that top left, which is their priorities, and then the other boxes are like, I want to work on it later, or I don't want to work on it right now. So really what we start to do is, if they put like, mental health or addiction in the I don't want to work on it right now category, it just really gives us the opportunity to ask some questions and do some motivational interviewing. So, oh, I noticed that you put this in that box. Why did you do that? Can you tell me more about it? So it's not that we would never talk about it with them. It's just that we wouldn't address it right away. We would probably maybe bring it up later in conversation.
But to answer the overall question, there are plenty of patients that we have graduated from our program who still are using substances. Again, the idea is that we want to address what they want to work on. If they're not ready to address those aspects of their health, we're not going to do so. It's kind of what we said, a frame shift. We believe fully in harm reduction here. So we'll attempt to reduce whatever the negative consequences of that substance abuse is, but we won't try and fix the behavior itself unless the patient has expressed a desire to do so.
Yeah, our frame is really, as long as there's something that the patient identifies that we can help them work towards, we're going to work with them, regardless of whether or not, they're ready to make a change with, with their addiction.
Great. It looks like that is all our questions right now, so please feel free to continue.
I just wanted to reflect that on the question about how to change doctor or provider behavior. As a family doc myself, some of it seems to be just repetition and more feedback, because I remember training our team many years ago at a community clinic on motivational interviewing, and a lot of doctors switched from you absolutely need to quit smoking to you need to quit smoking. Don't you think you need to quit smoking? Which is kind of a perverse way of thinking. So again, I think like any new skill, providers included, it needs a lot of practice and will probably be done badly before it's done well.
Absolutely, that summed up perfectly.
Yeah, I think, just kind of giving people the space, to talk about this stuff too is really important. We did a training recently with a community organization that's kind of similar to ours, but they work with pregnant women and families in Camden. And we did an activity that was very grounded in observing a normal routine. So it was a bunch of patient scenarios, and then, we asked them, what would you do to observe this patient's normal routine? And as people were going around, they were like, wow, if I encountered this situation yesterday, I would have stepped in and problem solved for the patient. But just sometimes, stepping out of the work and just creating a forum where people can kind of talk through a lot of this stuff is really important.
Great, well, thank you. Well, why don't you continue with the presentation as we're done with questions for now.
Great.
Perfect. So for the last few minutes, we're just going to kind of address some of our lessons learned over what we've, experienced since our organization began. So we're going to discuss hire for attitude, not licensure, rapidly iterate, facilitate communication, and address burnout. So what do I mean by hire for attitude and not licensure? Well, as we started to grow as an organization, we recognized that we needed to hire more clinical staff. And what we learned very quickly is that your resume, your experience, and even the number of letters you have at the end of your name doesn't necessarily correlate to how good of care you provide. And more importantly, it doesn't necessarily dictate your philosophy. And instead, we shifted from that being a priority to just making sure that their attitude is in line with our care tenets and our organization as a whole. So how do we do this? Well, what we do is we actually have group interviews. So let's say that we want to hire for an LPN position. We'll have 5 or 6 LPNs come in, and then we'll show them a polarizing topic. So usually a video such as harm reduction at a safe injection site in Vancouver, Canada. Now this naturally is a topic that causes individuals to kind of split down the middle, right? They're either for it or against it. There is some gray area in between, of course. But the idea is that when we facilitate a discussion via questions and just open dialogue, and we can quickly determine who is in line with our attitude and who isn't. It doesn't mean that we're right and we're wrong, but we just want to make sure that the people we're hiring are going to show compassion and respect to our patients in line with the rest of our team. The second piece is that we have long interview days. So this is kind of in line with that last piece, right? This is really hard work. So what we'll do is we'll have all the individuals that are here for the LPN interview, as an example, then split up and meet with smaller groups of employees. So maybe they'll meet with 3 or 4 people from data, then 3 or 4 people from I don't know, legal and resources or human resources, things like that. And by the end of the day, so we'll do this for a number of hours, and by the end of the day, we're going to ask them some difficult questions. And we want to make sure that their attitude is still there and that they're still in line with our beliefs, even when they're tired and drained. Because again, this work is not easy, and we want to know how an individual is going to react and treat a patient after a long day. And finally, for the candidates that we bring back, we have them accompany our care team on a home visit. So they'll actually go with a member of our team to meet a patient in their home. And our team is trained to kind of recognize the patient's, the candidate's body language and what they say, such as during maybe the ride home or even to the patient themselves. And from there, we try to make sure that we hire individuals who are in line with our attitude. The second piece is that we want to rapidly iterate. So I have posted kind of a fun picture that demonstrates just one of our many reorgs within the coalition. The idea is that, we've worked with a lot of sites across the country, and what sometimes they unfortunately do is they hear about our work and they build out a care team, and they take on a huge panel size, and they immediately start to protocolize and build processes for all of the interventions, so all of the the day-to-day work. But then when they jump into the work and they start working with patients, they realize that they've taken the wrong path, and they need to pivot over and over and over and over again. So our suggestion is, if possible, to start small. So we like to highlight a few patient cases and really dive into the work and find out all the little aspects of patient care for the complex population that we serve. And from there, we iterate and we rebuild and we restructure as needed. And only then can we start to protocolize and build out processes for reproduction.
Great. So again, going back to that theme of, this work being really hard, we've definitely saw the need over the years to just have more strategies in place to really talk about this work as a team, to make sure that no one's getting overwhelmed, to make sure that no one's getting siloed in the work. And these are just the few ways that we do that with our care teams. So first and foremost is the daily team huddle. This is a pretty informal gathering of both teams each morning. And it's a really great way just to talk about priorities for the day or goals for the week, and just to get the whole team motivated. I think every morning the team ends with a group high five. So it's really, really sets the tone for the day or for the week for the team. Really serves as a source of, motivation for everybody. And then secondly, we also have weekly panel updates. So this is where, an LPN will sit with one of the clinical managers, and they'll essentially go one by one with every single patient on the panel to get updates, to see what progress has been made, and to see if there's any barriers coming up. And then we also have readmission deep dives. So these are meetings that happen biweekly that focus specifically on patients that have been readmitted during the course of the intervention. So it's really a root cause analysis to see, why did this person go to the hospital, and how can we address this issue in the future. And then lastly, with the coach model, but also across the board, training is really important. So training regularly, but also training uniformly. So we, of course, don't want disciplines to get siloed in the work. We feel like, the knowledge that a social worker has should be the same knowledge that a nurse has, and vice versa. We find that, again, with complexity, that we all really need to be approaching this work in the same way, with the same knowledge and the same philosophy. And next, I want to talk about external communication a little bit, because, of course, coalition is in the name of our organization, because we find that building a coalition around this work in the community is so important. And one of the ways we do that, which is actually a very simple meeting, but it's actually really incredible, is the monthly care management meeting. So this is essentially a monthly meeting that's open to anyone in the city, and it's really an opportunity to discuss patient cases, to learn about community resources, and to network and start to build relationships within the community and start to create buy-in and support around this work. So just to give you a rundown of what a typical meeting looks like. So usually there is a guest speaker from a local resource. So this could be perhaps a new food pantry that's opening, or a new pharmacy that's opening in the community. And then there's also the opportunity for an anonymous case discussion. So this could be one of our care team members. It could be somebody from a local hospital, presenting a patient that they're currently working with, a barrier that they're facing, and really using all the heads around the table to come up with a creative solution. Again, it's really about, not getting siloed in the work, but really involving everybody in the process. And then lastly, just highlighting the successes of this meeting. We've been doing this meeting probably for almost 5 years or more at the coalition, with some really incredible results. And then last but not least, I just want to talk about burnout, because again, we find that we can't serve our patients well if we're not taking care of ourselves. So it's really important to us that we really have strategies in place to address burnout when it does come up, because it will, is what we found in doing this work. So I'm just going to briefly talk through some of the strategies that we use here, or some of the strategies that our partners use. So one of the strategies that a partnering organization, actually this is Corey Waller's group, uses, are empathy or burnout checks. So essentially, I think the whole team just sits around a table every day, and they just basically talk about how they're feeling. And if somebody is saying, I just can't work with this patient today, the panel is adjusted accordingly. So this really gives people the space, to be burnt out, to not have to work with somebody that's gonna, emotionally trigger them that specific day. And then next, we're really fortunate here that we have a very generous PTO policy. So every employee gets about 4 to 5 weeks of paid vacation a year. And again, this really just gives people the space to step away from the work, to be sick if they're sick, to be with their family if they need to be with their family. And then something that Jeff is actually a really big proponent of is mental health. So obviously physical health is important, but mental health is obviously also really important if we're going to work effectively with patients and with our partners. And so we get dollar-to-dollar coverage up to $2,000 that we can use either towards individual or family counseling. And then we also have strict office hours. So we're very much a 9 to 5 organization. We try to leave the work here as much as we can. Our care teams do have phones that they use for work, but at the end of the day, those phones get left here. So again, it's all about being able to step away from the work at the end of the day and being able to recharge. And then lastly, we have team retreats. So this is a picture of us whitewater rafting. So about once or twice a year, we'll shut down the whole office and we'll go do something fun. And again, it's really all about stepping away from the work and just being able to enjoy ourselves and enjoy each other as colleagues. So that's actually our whole presentation for the day. Again, it was a high-level overview of a lot of stuff, for lack of a better term. But we would love any questions that you have about what we just talked about or anything that we've presented this afternoon. And we're just, yeah, thank you again so much for inviting us to present. It's been fun.
Well, thank you. I always learn from you when you present your model, and it seems like every time I hear you, you've changed something, which is a great sign that you're constantly improving. I did want to reflect that we've heard from the coaching calls with Corey Waller that he's been also repeating the messages, start small. It's so common when we want to fix a problem to start big and then find yourself having to undo a lot of the things that we did. So again, it's a great message, start with a small number of folks. We do have one question.
So the question is around, you talked a lot about how your teams function together and the things you do to support a high-functioning team. But someone asked a question about sort of how do you approach when a team loses, so to speak, or how do you do any failure analyses of how a team is functioning?
Yeah, so I mean, in terms of the failure piece, I would love to hear kind of a little more information on that. I mean, in terms of failure, you know, the opposite obviously is success, and internally we really try to kind of redefine success to kind of embrace failure, if you want to call it that. So an example is that, you know, we emphasize here that, you know, failure is not a patient being readmitted to the hospital. That's not a failure. That's what happens. It's very unlikely that we're going to completely eliminate all hospital readmissions. And instead, we want to redefine success under the terms of, you know, A, are we at least impacting their hospitalization, and B, and probably more importantly, are we improving their quality of life? So I think that, you know, in terms of a failure, that's something that we'd have to kind of think about. But, you know, we're very vocal in terms of, you know, the communication aspect, as Kat spoke to. So, you know, a failure is something that would most likely come up during a readmission deep dive, or even during, you know, a morning huddle when we're trying to really kind of address all these things and prepare us for the rest of the day. And as a team, we would like to kind of discuss it.
Yeah, I would say the other thing too is when Brian showed the dashboard earlier that shows, you know, is the team getting to the patient within 1 to 2 days of discharge from the hospital? Is the team seeing that particular patient, or, you know, all of their patients at least once a week? So that dashboard is actually something that our clinical teams see on a regular basis. So they are actually, you know, able to see their own metrics as a team and see if they're making, you know, kind of making the mark, so to speak. And that, you know, also creates a sense of accountability and creates the space for a conversation, you know, around, okay, well, I see that your hours are down this week, or I see that you're having a lot of trouble seeing patients within 7 days. You know, let's talk about that.
Thank you. Another question came in saying, has this coach model been adapted in a larger city than Camden? And how did that roll out, if so?
Yeah, that's a great question. So we have technical assistance sites across the country that we contract with for a year, and we do year-long curriculum with them about, you know, various aspects of our care philosophy, but coach as well. So one of the systems that we contracted with last year was the Sutter Health System in California, which is a huge health system. And, you know, we did share the coach model with them, and I think we're still, you know, trying to figure out how do we actually measure impact. You know, when we do introduce this model, how do we actually figure out if people are using it? So another way we've started to introduce the curriculum externally is through our student hotspotting program. So we have about 20 different schools across the country that we work with. They each form interdisciplinary care teams, and we essentially train them on, you know, how to engage patients in their communities. And so coach is something that we've trained all of them on too. But I think, yeah, we have to start to think about, you know, how do we actually evaluate the rollout of coach externally.
Yeah, and the truth is that we would love to hear, you know, how it works. You know, external to our own organization, you know, we have a lot of, we've given the coach model, you know, a lot of time to be worked out and piloted, and we think that it works well for our staff. But again, you know, that is our organization, that is our city and our population. We're not suggesting that it absolutely will work, but that's why we want to hear more about it, and we want to continue to train other organizations, especially those in, say, a larger city, as was asked, and see how it works. You know, it's up to, you know, we unfortunately are only located in Camden for the time being, and it's kind of up to other sites to kind of take our model and, just as you're doing in California, take additional models and then kind of find out what works and what doesn't.
Thank you. It's very, very helpful. One question we had here at CHCF is how is your model funded and what kind of contracts do you have with hospitals or health plans? And since these teams are working both on care models and finance models, and I'm not sure if you're the right people to answer that or if you could give a high-level overview.
Absolutely. We can give a high-level overview, but we'll be happy to connect you with individuals or even find out more specifically for you. But we are primarily funded by grants. So we essentially have three sources of funding for the most part. Grants, which is predominant. We also have, as Kat kind of alluded to, technical assistance contracts throughout the country, which helps to provide income. And then thirdly, we actually have just been approved for an accountable care organization, so ideally shared savings will assist in the future.
Great, thanks. We're going to do one last check to see if there's any questions, but obviously we do have ways to get those questions answered afterwards if anyone comes up with something after the call. Thank you again for your time.